Hello, everybody. How are you? Stephen Hall. I know that there are a number of you logged in, and welcome, and we will probably have more people logged in over the next 5 to 10 minutes with a bit of luck. This is the first of the new version of the Journal Club, which is sponsored by UCB, but in which UCB does nothing other than provide the technology and the support. They played no role in the decision as to what we talk about or who will speak. The 3 people who are organising this year will be myself, Paul Bird and Marie Felletar, but we'll have, hopefully, both national and international speakers presenting. The idea of this really stems from the fact, the recognition that lots of us no longer maintain active involvement with any teaching hospitals. And while the teaching hospitals serve an important part of rheumatology continuing education, particularly for advanced trainees and people who are full-time staff or heavily involved with teaching hospitals, the absence of involvement with teaching hospitals and the involvement in our own lives means that we have a little gap in our traditional education program. And the aim of this was to see whether we could outreach and to have more people involved in such a program. So it's so what will happen is that people can type their questions, and I'm happy, and I will read out the questions and reply. I would encourage everybody to feel free to butt in and to talk, interact in that way. It's a pity we can't have speak and organise chaos, but this will have to do. We've done this as last year we had a beta version, which was a very clunky setup. This is a much more user-friendly setup. And so I thought we would head off with the issue of palindromic rheumatism, a topic that, a condition that most of us see, but about which there's relatively little written. And it's a condition that I'm fairly fond of. This really comes from an old paper from Joseph Smolens's group, talking about the benefit of very early referral and very early therapy for rheumatoid arthritis. So the idea was that you had what they called a very early, which was less than three months, and then there was late, which was more than 12 months. And they would claim that in this, what they had was a difference in the ACR response between the 2 groups, depending on how early people were treated with disease-modifying drugs. And this has formed part of the general push for all guidelines that people should be seen early and treated early. And we have lots of people who say that they will treat early, and others who recognise that there are difficulties in getting patients through our waiting list and through hospital waiting list to allow them to be triaged to be treated early. And that's a real problem, in part because we've got long waiting times, in part because patients have a delay in going to see the doctor, in part because the doctors have a delay in referring, and in part because the people that doctors thought had rheumatoid arthritis often don't, and the people the general practitioners thought didn't have rheumatoid arthritis all too frequently do have rheumatoid arthritis. And so we've seen, all of us who are here have seen that sort of problem all the time. Palindromic rheumatism is an interesting disease because it may help address the question of identifying the very early rheumatoid patient. So we need to show the clinical picture of rheumatoid arthritis for early referral. We can identify them by the picture of palindromic rheumatism, and that's an issue that I'm going to talk about a little bit. We can try and identify them laboratory testing, and we can look for people who've got arthralgias, which is to say joint pain with no objective findings, who've got positive tests or imaging, and then treat them aggressively. The last 2 ACRs have had quite a lot of papers talking about the idea of treating pre-rheumatoid, the idea of addressing and identifying those patients who have rheumatoid arthritis before they develop established disease, and then treating them aggressively so as to hopefully get rid of the potential to express that rheumatoid disease, and then we would treat them aggressively. Does it matter? Who cares? Well, I think Australia cares a little bit in rheumatology, mainly because we have Ranjani Thomas and her group with Rheumovax, a dendritic cell vaccine, which is designed to stop the development of rheumatoid arthritis and to arrest it and hopefully reverse it. Last year, Ranjani published a paper looking at the tolerability of this vaccine in a small group of patients. And while the trial was directed primarily at looking at whether the vaccine was safe and whether it would induce any problems, which fortunately it didn't, it also proposed that people improved, although it's fair to say that the design, being an open-label phase 1 study, was not really in a position to make any dramatic statements in that regard. But there were anecdotal reports that people felt better and had a lessening of their DAS-28 scores. We've seen that with so many other things, that people look to do well until you have a placebo arm, but it remains to be seen whether that promise is going to be met. But at this point, one of the candidate entry points for people entering vaccine studies may well be those patients who have palindromic rheumatism. So it may be that window of opportunity, and the question is when to time that intervention. Palindromic rheumatism is a term that was coined back in 1940 by Philip Hench and his colleague Rosenberg. Hench, for those of you who love history, was the first head of rheumatology at the Mayo Clinic. And some years after this observation, he went on to introduce cortisone into medicine in 1949, for which he later won the Nobel Prize. People who are interested in that sort of history should look up Kevin Fraser's article on the history of the development of cortisone and Philip Hench's role, which was published in Annals of Rheumatic Disease quite some years ago. It's a fabulous article, and it really outlines what happened at the time. But Hench had a brother-in-law who was a professor of classical Greek. Hench was always a competitive person, and Hench had an old-time repair of a hair lip and cleft palate. So he had a characteristic speech abnormality that we see with that. And so Philip Hench used to speak like this. But he just, and in his day, he was one of the 3 or 4 most prominent early rheumatologists in the United States. They described 33 patients who had this episodic monoarthritis with swelling. And it would last for some hours or up to a few days to a maximum of about a week. And often there would be overlying erythema. And these patients were followed for some years before they published this report. And in no patient did they ever evolve into any permanent damage. He referred to a palindrome, which this really isn't, because with a palindrome, the word like Glenelg or a number like 124, 1234, 321 is the same backwards and forwards. What he's referring to in this is that the joint after the episode is the same as it was before the episode. It's not the symmetry of the episode, but the fact that it starts off normal and reverts to normal that defines the palindrome. Just as an aside, you'll see there's a Q&A section on your screen. Feel free to type in any questions and interrupt me at any time, and I'm happy to try and reply. So that was the basis of palindromic rheumatism as it was first described. Philip Hench thought it was a disease separate to rheumatoid arthritis, and Walter Bauer, who was the famous rheumatologist who set up rheumatology at Massachusetts General, thought that in fact it was a variant of rheumatoid arthritis. They may well both be right. This is one of the first criteria for diagnosis of palindromic rheumatism. There have been a number proposed, and fundamentally they follow the same. They follow the same basic criteria, that it's this history of brief, sudden onset, recurring attacks of monoarthritis. And you can't establish the diagnosis with any accuracy unless a physician actually sees them in an attack. For many of us, it's our policy to arrange to see people as a matter of Typically, they have more than 5 attacks in the previous 2 years, though I'm not really sure of the basis for making that sort of statement. They're looking for people who have more than one joint involved in attacks, and ideally 3 or more. And of course, they demand negative X-rays in acute phase reactants. The first criteria demanded a negative rheumatoid factor, but as we'll discuss, that's really not generally thought of as being required. And in the subsequent criteria, that criterion has not been demanded. And that's of important prognostic significance. There have not been that many reports of joint fluid analysis, but when it's been done, it's typically not as inflammatory as you would think for something that has overlying erythema. The joint fluid usually shows a monocytosis rather than a profound neutrophilic reaction. And the synovial biopsies, which were initially reported by Hench and have subsequently been reported by a few other authors, are rather non-specific. The original report showed a polymorphous infiltrate. And Ralph Schumacher, who has been a king of doing that sort of investigation with synovial biopsy and joint fluid analysis, suggested that the synovial biopsy doesn't really typically suggest rheumatoid arthritis during an attack, even though for all the world they look like they've got an intense inflammatory arthritis. And the radiographs typically are quite normal. So when I was a boy doctor, sadly a long time ago, the question is, what was I taught? And I was taught that some of these people resolve, some of these, and it goes away, and we presume they're viral in origin. Some patients have persistence of damage, of attacks rather, and so they keep getting recurring attacks, and they never damage the joint. And I've certainly seen patients who've reported 40 years of palindromic rheumatism, during which time they've had hundreds of attacks, and their X-rays are perfectly normal with respect to any rheumatoid change. And I was taught that most people eventually evolve into rheumatoid arthritis, and that the people who evolve into rheumatoid arthritis typically have a positive rheumatoid factor at presentation. So we would look on palindromic rheumatism often as being an immediate precursor to rheumatoid arthritis. And presumably it's that line of belief that has led to the Queensland group under Ranjini Thomas looking at palindromic rheumatism as being the group to target for vaccine therapy or other interventions. So where are we today? Well, it was thought initially to be rare, and when one asks around one's colleagues, there's extraordinary variability in what people think. Some people think that this is a very common disease. Some people think this is a very rare disease. The last patient whom I saw this evening was a lady whom I saw 5 years ago and diagnosed palindromic rheumatism, and she's been well, but she's come back because she's had 1 week of severe ankle pain and swelling, and then booked in to see me as a matter of urgency because this was the worst attack she'd ever had. But by the time she arrived tonight, it was already very much on the improve, and we've adopted a wait-and-see approach. The frequency was initially thought to be about 1/20th the frequency of rheumatoid arthritis. Anne Powell, when working in Edmonton, and I think Anne's probably on the line at the moment, but Anne was demonstrated in a review of the people, in a review of the cases from Edmonton, that these people will frequently have, was occurring fairly frequently. And they suggested that there was about 1 case of palindromic rheumatism for every new case or every 2 new cases of rheumatoid arthritis seen by the people in Edmonton, which is an extraordinarily high rate, and that would certainly be higher than my personal experience, but it was derived from the review of charts over a 3-year period of a number of rheumatologists in Edmonton. Looking at it the reverse way, and if we look at people with rheumatoid arthritis, not the people with palindromic rheumatism, but if we look at people who are diagnosed newly with rheumatoid arthritis, between 10 and 20% of them report a palindromic pattern of onset. And that's certainly what many of us have seen, that in retrospect, they've had a number of episodes. And rheumatoid factors positive in about 50%, and ACPAs, the CCP antibodies, are positive in another 50%. And one would have thought that these are the patients who serologically have declared that they're destined to go on to rheumatoid arthritis. And that would be the assumption, that the ACPA-positive patient with palindromic rheumatism is really a sitter to go on and develop rheumatoid arthritis. So we have potentially the identification of a clinically expressed pre-rheumatoid state. This comes from a group, this particular figure comes from a group from Spain. And if you have a look at this figure, and we'll look at the two firm lines, the two full lines, one being ACPA negative and one being ACPA positive. And what we see, and the two bold lines, and what we see is the ACPA positive people are more likely to develop rheumatoid. But in this patient population, you can see that the majority of people, even when ACPA positive, even when followed over 13 years, never went on to develop rheumatoid arthritis. So it may be that perhaps this is not what happens. In this patient group, there were 71 patients, and the probability of developing rheumatoid at 1 year was only 7%. At 5 years, it was 17%. And at 10 years, it was 26%. To go back to the question of how common it is, Anne Powell contributed that she was surprised at how common it was in Edmonton, far more than she saw at the Alfred or in private in Melbourne. And I think that would be my view too. I think that it's the reported figures, the figures that Anne reported from Edmonton, are well in excess of what I've seen in my practice. But certainly I've got several hundred patients with palindromic rheumatism on my database. Now, many of those have gone on to rheumatoid arthritis, but there's certainly several hundred patients out of about 55,000 on our database who developed, who presented with palindromic rheumatism. The Canadian series reported a different experience, that's the Edmonton group, to the Spanish group. They reported that 24 of 34 who were ACPA positive, and you will recall that ACPA has a number of specificities, and the one we usually routinely test in practice is CCP number 2. That's the one that our commercial kits are really assaying. And so if we look at the CCP2 positive patients, 24 of 34 evolved into rheumatoid arthritis over a number of years of follow-up. 3 of 27 who were negative for ACPA evolved into rheumatoid. And the ACPA was more predictive for rheumatoid arthritis than the rheumatoid factor. So in that sense, it seemed to have greater predictive value. Probably they were most at risk of developing rheumatoid arthritis in their first year of symptoms. And so it could well be that the Spanish group identified people who'd been going for more than a year, and so they'd already selected out the people with rheumatoid arthritis who were going to develop rheumatoid. The other possibility is that treatment may have altered the expression of who goes on to develop rheumatoid arthritis, which of course presupposes that any treatment we have is actually effective. When we look at ultrasound or imaging during an episode, what we see is changes on ultrasound in the acute episode. We'll see some thickening, maybe an increase in power Doppler signal during an episode. But even then, that's only found in a minority of patients. And synovitis is found in a slightly higher proportion of patients when assessed by MRI, though the number of patients in those series is really very small. The question is that if they're going to go on to develop rheumatoid, one might have expected that in the interval you will see changes. This paper comes from Mankia. This was not in press, but was an abstract that was at the ACR, and it comes from Paul Emery's group at Leeds. And they collected a collection of patients with palindromic rheumatism, 15 patients, and a collection of patients who were CCP positive and CCP negative. And so what we're looking at here is we've got a little problem with the columns. So what we're looking at in the first two columns is CCP positive palindromic rheumatism, CCP negative palindromic rheumatism, and the third column that we're comparing it to is people with early rheumatoid arthritis. And what you see is that they saw synovitis, they saw tenosynovitis, they saw a little bit of peritendinous edema, they saw periarticular inflammation very frequently, and they saw subcutaneous edema. When they looked at them in MRI, and you can see there's much smaller numbers of it during the MRI, they saw lots of synovitis and tenosynovitis, peritendinous edema that they didn't see in early rheumatoid, with periarticular inflammation. And they saw they didn't see bone marrow edema in general, and they certainly didn't see erosions as they saw in rheumatoid. So there were differences in the MR appearance on of patient with rheumatoid versus palindromic rheumatism. When another Spanish group looked at this in between attacks, the ultrasound of the joints was perfectly normal. So it wasn't a question that the palindromic patients had a low-grade synovitis that wasn't evident clinically, but evident on imaging. They really were perfectly normal in between attacks. And in essence, what they saw was 4 out of 54 had some ultrasound evidence of synovitis in at least one joint. So it was only 4 out of 54 patients who had any changes. This is an extraordinarily small number in a group where by anybody's reckoning, a significant proportion are going to go on to rheumatoid arthritis. In terms of treatment, the data on treatment is really fairly pathetic. All the data is retrospective. There's never been a prospective study. And the best data supports the use of Plaquenil, where there's a suggestion of a sort of delay to evolution to rheumatoid arthritis in the Plaquenil-treated patients compared to those patients not receiving Plaquenil. And there was a high rate of remission of disease, or at least major reduction in frequency in patients on Plaquenil. There are some very, very old series looking at chloroquine, penicillamine, colchicine, cilozaparin, and dapsone. And while we are all in love with methotrexate and will frequently use methotrexate or biological drugs in these people, there is absolutely no reported experience on the use of either methotrexate or biological drugs in the treatment of palindromic rheumatism. So if one wanted to do a little study with a registrar, that's the study to do. There's a real hole in the literature on palindromic rheumatism and its treatment. It'd be interesting if you could type in whether any of you have what your favorite drug is for treating palindromic rheumatism. Feel free. So what we're seeing here is a lower rate of evolution to rheumatoid arthritis than one would really like to see if you're going to initiate a treatment. And that's a concern, because if the rate of evolution of palindromic rheumatism to typical rheumatoid arthritis is occurring so slowly, it may well be that the number of patients required to be treated in a clinical trial will make it not feasible. But that's not an issue for me. The people who are devising clinical trials for what one might term pre-rheumatoid. So that's led people to look. So there we are. We have a couple of people who would use, 3 people who would use Plaquenil. Is there anybody out there who would use methotrexate to treat palindromic rheumatism? I did run these slides past Peter Wong, and he's used methotrexate preferentially because he thinks they look like rheumatoid arthritis and they should be treated. And he reports good results, and I've certainly had some good results in people who were placed on Plaquenil and didn't respond. We're still keeping on going on the survey. We're still keeping on going with Plaquenil. So Plaquenil gets a good run for this, which is in keeping with the literature. Who says rheumatologists aren't evidence-based? So the next question is, for those of you who've been to the AbbVie courses on how to do ultrasound for fun and profit, can ultrasound tell us if rheumatoid arthritis is developing? So, using the ultrasound to identify people, the idea was that this group looked at consecutive CCP-positive patients with musculoskeletal complaints without synovitis. And they reported 136 patients who had arthralgias who were CCP-positive. Now, to my mind, that seems like a hell of a lot of patients. In fact, I can see very few people who are CCP positive and have arthralgias who don't have clinical signs of rheumatoid arthritis. But this group from Leeds, that's what they're reporting. So that's interesting. Maybe Paul Emery can do stuff that the rest of us can't. Paul certainly believes that sometimes. So what they have here is their symptom duration. And you see that 73% of them were female, and most of them had a disease duration, of two-thirds of them had a disease duration of more than 12 months, with a mean disease duration of about 18 months. Some of them have been going, you can see, up to 328 months, which is an extraordinarily long time. They had an average disease duration of 5, average number of joints of 5, of 20 joints, and the reason they've chosen 20 joints is that's the number of joints that were surveyed on ultrasound. So of the tender joint count of 20, a tender joint count of 28, they had 1. Localization of clinical tenderness was predominantly either in small joints or small and large joints, with a few people having large joints. But you can see that a significant proportion of them, which is about 40%, had no tenderness to finding at all. And you can see that half of them had 1 copy of the shared epitope, and 20% were homozygous for a shared epitope. And the autoantibody status was the vast majority had a high titer rheumatoid factor, or CCP, and the 20% of them had a low titer rheumatoid factor, or CCP. Remember, all of them had to have some serological evidence. They had 48 normal controls, and they did grayscale ultrasound, which really tells you synovial thickening, and they had power Doppler. And what they report is that the grayscale score in this pre-rheumatoid population was 4, and it was 0 to 3 in 20 joints. So you could have up to a score of 60. So the median grayscale was only 4, except the first MTP. And the first MTP frequently has synovitis, probably reflecting some osteoarthritis rather than anything else. And only 1 patient had power Doppler signal in any joint. Now, when you looked at these people, the survival plot of these patients showing cumulative inflammatory arthritis according to the power Doppler signal in any joint, you can see that if you had a negative power Doppler signal, which is the green bar, your cumulative clinical synovitis free rate was extraordinarily high. And if you had power Doppler signal of 2, which goes 0 to 3, your chance of being free of synovitis at 5 years was only about 35%. So they would suggest that the finding of power Doppler signal was a predictor that you'd go on to develop inflammatory arthritis. The Dutch looked at this also in 2010, and they reported 192 patients with similar criteria, of whom about a quarter developed synovitis by 11 months. The problem here is that the inter-observer variability for synovitis and power Doppler is terrible. And and it's even lower for a joint effusion. So there was a trend towards prediction, but it didn't reach significance. So ultrasound may not be. So if you had no power Doppler signal, 50% had inflammatory arthritis by 5 years. And if you had any power Doppler signal, 80% had inflammatory arthritis. So it becomes really a bit questionable as to whether this is going to be the best way to detect what's going to happen. And if it is the best way, it's going to take an age before we see the changes. So this has then led people to continue to look at this. And Gerlag, who works with Paul Peter Tak, and like Paul Peter Tak has now gone to industry with GSK, having left academia in the Netherlands, had a review article at the end of last year in Rheumatology, which I think is a terrific article and one which I would commend people to read. We will be having, in a week's time on the website, there will be all of the key articles that I'm referring to for review. So the bibliography will be there, but the key articles in full text will be there for the ones that I'm talking about. So the Gerlag paper looked at reviewed ways of looking at how you could prevent developing rheumatoid arthritis. And they looked at, and they observed, as people have, that you can see in stored sera that elevated acute phase reactants, cytokines, and chemokines precede the development of rheumatoid arthritis for years. We know from work from Stanford and from other groups that there is a spread of the epitope of CCP. So what we see is over time, if we've got serum, we will see that the number of different specificities of CCP expands, so we get more specificities becoming evident over time. And it's thought that by the time people develop clinically evident rheumatoid arthritis, the epitope spread has guaranteed non-reversibility of the disease. So the hypothesis is that you want to intervene and introduce some vaccination or intervention before you've got dramatic extension of that epitope, before that epitopic spread has become manifest. There's a median of 5 years between onset of disease, a median of 5 years, such that by 5 years, if you can look at people with serum 5 years before, more than an average of 50% have got rheumatoid factor or ACPA evident on stored sera. And on synovial biopsy, at the time of first diagnosis, within weeks of onset, we will already see all the changes of chronic inflammation. So it doesn't look acute inflammatory at all. It doesn't look like something that is in the reversible state. It looks like something which is already well established and may well be irreversible. So they looked in this, and so they reviewed the literature looking at pre-rheumatoid before inflammation. And they did that. They found people whom they thought were at high risk, and they did MRI and synovial biopsy. And that was done with Paul Peter Tack's group, and also with some Australian contribution in the initial papers from Malcolm Smith, who had a big interest in this type of synovial biopsy and synovial pathology. And what they found was that you could see vascular changes in inflammatory cells at times, but that the presence of those vascular changes and those inflammatory cells were not even vaguely predictive of who's going to go on to rheumatoid arthritis. So the finding of the inflammatory cells early on is not a sign that that person is destined to get rheumatoid disease. And that's led people to look outside the joint at the concept that the driver of rheumatoid arthritis actually isn't in the joint itself, but it lies elsewhere. And if you do fine needle aspirates of the joint, fine needle aspirates of lymph nodes in both animal models and in humans, before the joints become involved, one will see activation of lymphoid cells in those lymph nodes. Lung changes are seen earlier on imaging preceding the development of rheumatoid arthritis. And we have all of the information that's come out on periodontal microbiome, which has grabbed so much attention. Australia actually did very well at looking at periodontal microbiome, and Alex Klestoff had a paper years ago in Hobart at one of the ARA meetings looking at periodontal changes in patients with rheumatoid arthritis, well before the rest of us were looking at that type of thing. Quite prescient. But the periodontal microbiome has grabbed lots of attention, and there were papers about, while one particular organism has grabbed most of the attention, there was a paper at this year's ACR identifying a new organism, new organism association, which may well be more specific and more amenable to intervention than the previous association. The gut microbiome, of course, is very hot in terms of biology, but hasn't been so thoroughly characterized in rheumatoid as it has in the spondyloarthropathies. And so the evidence for the gut being the primary site of the microbiome, not so strong there. So these people proposed, very innovatively, that a single dose of rituximab might switch off the disease, and if it reduced the rate of development of rheumatoid arthritis by 75% at 4 years, it would be cost effective. So that's what they've set themselves, and that was of interest, and because it came out about the same time. And Powell's asked the question about another pre-rheumatoid state. Is monoarthritis CCP positive, with studies suggesting methotrexate for prevention? And do we think it's related to palindromic rheumatism or different? My own view is that I would see it as being different to palindromic rheumatism, where the characteristic thing is not the monoarthritis, but the fact that it totally reverses, that it has that quasi-palindromal pattern where after the attack the joint is as it was before. The question is whether, if you've got a monoarthritis with CCP-positive disease, whether it's truly a monoarthritis and whether there is actually symmetry. So if one got one wrist that was swollen with CCP-positive and you scanned or biopsied the contralateral wrist, would that not show changes? There is early evidence from years ago of showing that if you had a rheumatoid in one joint on one side but not clearly evident on the other, particularly in a knee, and you biopsied the clinically silent side, it would frequently show chronic synovitis, even in the absence of clinical findings. So I think the assumption that the clinical definition of synovitis is the be-all and end-all in that context may not be really true. And it'd be very interesting to take that group of reported patients and then to do MRI and ideally biopsy of the contralateral side and see just how monoarthritis it really was. Going back to this prairie study, Gerlach, the same person who with Paul Peter Tack spoke about a 75% reduction at 4 years being cost effective, presented the prairie study at ACR in Washington late last year. And they used a single infusion of rituximab of 1,000 milligrams to try and prevent development of rheumatoid. Fascinatingly, the abstract noted there was a patent pending. So there is money in them there hills. They looked at patients who had arthralgia, which by definition was joint pain without the demonstrable synovitis, who had an elevated rheumatoid factor and ACPA, or a CRP, which was above the upper limit of normal, or subclinical synovitis on imaging. The problem with that is that on imaging with MRI, the background rate of synovitis is alarmingly high. The background rate of apparent erosions is also alarmingly high. So the finding of relatively modest clinical signs and a positive MRI is of questionable specificity. And that needs to be taken into account both in our clinical practice and in looking at these particular results. They were randomized to either rituximab with 100 milligrams of methylprednisolone or 100 milligrams of methylprednisolone alone. So they would have been well blinded because they would have got the steroid buzz from the methylprednisolone. They screened 109 patients. 27 failed screen, 82 were randomized, 1 withdrew consent, and that left 41 active patients to be evaluated with 40 placebo patients. So it's a good-sized trial. And it was designed in such a way that it would have the power to achieve their levels, predetermined levels of response. And what they found was with rituximab, not surprisingly, as a B-cell active agent, which is going to knock down antibodies, that they had reduced levels of ACPA of all specificities. And there was a moderate reduction in the percentage who developed rheumatoid. Remember, their health economic analysis required that they have a 75% reduction in the rate of development of rheumatoid. That was written in the paper in Rheumatology at the end of 2016, but was not presented as part of their predetermined response criteria in the paper as it was presented at ACR. What they found was a minority of patients developed rheumatoid arthritis, 40% in the placebo group after a median period of 11.5 months, and in the rituximab after a median period of 16.5, a slightly lesser percentage. And that effect attenuated at 30 months. In other words, by 30 months, the two groups were coming together again, suggesting that the rituximab had delayed but had not permanently altered the propensity to develop rheumatoid. And they proposed that there might be a need for further infusions. In a sense, this has been seen as a positive study, a study suggesting that it might, that people might go on to give early treatment. But in fact, it didn't meet their prior outcome levels. and it really didn't provide evidence that it would permanently alter things. This is not the first study along those lines. The BMS people in the AVERT study with Orencia have hoped that their lymphocyte coactivation blocker would help. And what they looked at was people who had short disease duration. Short disease, they allowed people in who had less than 2 years of disease, which is not very short. But these people had a mean of only 6 months of disease. 95% were seropositive. And they were given either abatacept, methotrexate, or a combination of methotrexate and abatacept, and they were given treatment over 12 months. If they reached DAS equivalent of low disease activity, which is to say a DAS of less than 3.2, after 12 months, treatment was withdrawn, both methotrexate and abatacept, with the intention being to try and see whether they could enter maintained remission. And what we see in this efficacy assessment over time is that when you withdrew treatment, which was at the 365-day mark, the percentage of patients with DAS less than 2.6 was higher on the combination group than on the individual groups. And then that percentage dropped away, but continued to be better for quite some time on the abatacept-methotrexate combination. The same thing happened if you looked at lesser degrees of clinical response. So what they have here is when they looked at the bottom right curve, patients with a major clinical response and combined them, what you can see is that the combination group did better and that improvement continued out, but only a minority of patients had that. If you look at the Boolean remission, you can see that we're going to be hanging out there for a long time to see Boolean remission. That's the remission that's proposed, but the remission that's so rarely seen in practice. So we have these agents which are being given. The problem here is like in Indiana Jones, that we're still looking for the Holy Grail. And the question is, who gets it? If you remember that famous line, this man picked up the gorgeous-looking cup and was destroyed, and it was said of him that he chose poorly. Thank you very much. Please, are there any questions? And thank you for thanking me. It's now 8:45. Next time we will have a radiology case and we will have a little brief clinical case, which will then be a case of challenge, which people can then attempt to write in answers and justify their diagnoses. Not available, unfortunately, for today's case, but there will be a radiology case and there will be another clinical case for the next time. Thank you very much for your attention. I would remind people the next one will be on the 7th of March. I'm sure your UCB representative will be out to remind you of that time, and there'll be emails sent out to remind you as well. I hope we can see you then, and I'd like to thank UCB for their very arm's-length sponsorship and enormous technical support. Thank you very much. All the best. Good evening.